and we all are aware of this. An abnormal increase in blood pressure beyond physiological response that occurs after 20 weeks of pregnancy is called pregnancy-induced hypertension, which could be isolated, where it is called gestational hypertension, or accompanied by other organ dysfunction of the mother, which is preeclampsia. Hypertension during pregnancy is a major cause of avoidable death of the mother and the baby. If the mother and baby survive, they may suffer short and long-term consequences. So what is the Indian scenario? Nearly 10% of pregnant women in India develop pregnancy-induced hypertension. And when you translate this to numbers to the population of India, every year, nearly 24 lakh or 2.4 million pregnant women in India develop pregnancy-induced hypertension, which requires medical treatment. Now, requiring medical treatment could be a lot of burden on the healthcare system of the country. And there could be issues like availability of treatment or affordability or even compliance, because much of these women come from rural background. And this is my favorite chart, which speaks of the contribution of India to world. India contributes about 25% of the world statistics as far as adverse pregnancy outcomes are concerned. And the adverse outcomes are low birth weight babies, less than 2.5 kg, stillbirth, which is between 28 weeks intrauterine till birth, perinatal mortality, which is between 28 weeks intrauterine to 7 days after birth, neonatal mortality 1 month after birth, and infant is 1 year after birth. So all these are highly prevalent in India. And that is why we need to ponder, can we act? Can we identify women at risk of developing pregnancy-induced hypertension? Can we prevent or delay the onset of hypertension and thus decrease the number of women needing intense medical management for hypertension? And consequently, can we reduce the risk of morbidity and mortality of the mother and the babies during pregnancy? And that gave birth to Samrakshan. One pregnant woman dies of preeclampsia every 7 minutes. We can just talk about it, or we can join Samrakshan, where actions speak louder than words. So what is Samrakshan? Samrakshan is a national initiative or movement, or I would say mission, of the Indian Radiological and Imaging Association of India to address high rates of perinatal mortality, low birth weight, and preterm babies. The project was conceived and founded by Dr. Rijo Mathew, who was the first national coordinator of this project that was initiated during the presidentship of Dr. Hemant Patel. The program aims to reduce perinatal mortality in India through an approach that optimizes and integrates existing resources. So that means we do not need any special resources or special training or skills to participate in this program. It is our good old fetal Dopplers which we need to integrate in all trimester specific scans in pregnancy, which is recommended by Samrakshan. So when we integrate Dopplers in the first trimester, we determine a customized risk assessment for preterm preeclampsia and FGR for each pregnant woman. And when we do it in the second and the third trimester, it helps us in protocol-based management for preeclampsia and FGR. And all of this has been beautifully covered in the lectures. So Samrakshan has come a long way. The movement has gained a lot of momentum ever since 2019 when it was conceived. And here are some results of Samrakshan, and we'll see what we envisage for the future. So we have almost a dozen papers published in IJRI and almost 3 dozen published in Journal of Radiology. And I'll touch upon a couple of them. Discordant dating of pregnancy by LMP and ultrasound and its implications in perinatal statistics. High perinatal mortality in India may be caused by inaccurate dating of pregnancy resulting in suboptimal antenatal care. Now, what does that mean? So, if we have a wrong date, a wrong gestational age, we tend to underestimate FGR or overestimate FGR. We would deliver the babies prematurely or postmaturely, and any which ways it would add to high perinatal mortality. If we have the dating and the gestational age incorrect, the risk-based management of FGR will go haywire. As now we talk in terms of percentiles of biometry and Dopplers, and both the percentiles of biometry and Dopplers are gestational age dependent. So the first and the foremost thing is to have your gestational age correct, give a correct EDD to the patient, and calculate a correct LMP for the patient. This is a very important paper about reducing perinatal mortality in India. 2 years results of IRIA Fetal Radiology Samrakshan program, September 2021. The program was conducted in 38 districts and 16 states of India from 2019 to 2021. And as many women were screened in the first, second, and third trimester. And the outcomes were evaluated in 2,581 women. So the patients were followed from first trimester, where risk assessment was done, and high-risk patients were put on ecosprin, and till the outcome. So Samrakshan found that based on a cutoff of 1 in 150 for risk assessment in the first trimester, nearly 1 in 5 women in the first trimester may need low-dose aspirin, 150 milligram once at bedtime. And what is the impact of these results on India? The impact has been phenomenal. Pre-eclampsia reduced to 1/3, FGR reduced to 1/3, and preterm birth reduced to 1/2 in the districts which followed Samrakshan protocol. Neonatal mortality reduced from 15 per thousand to 9 per thousand. Perinatal mortality reduced from 26 to 18 per thousand. Stage 1 FGR carried to term significantly increased from 56% to 75%. That means almost 20% more women now persisted on stage 1 FGR till term. So the progression of FGR did not happen because these patients were put on ecosprin as they were diagnosed to be high risk for FGR in the first trimester. Stillbirth reduced from 16 per thousand to 6 per thousand pregnancies. Another paper, comparison of the mean uterine artery PI global reference with an Asian Indian population of pregnant women in the Samrakshan program, differences and implications. Now, gestational age specific global reference range of mean uterine artery PI more than 95 centile, which we all refer to day in and day out, was significantly lower than Indian data. So why is it that Indian women have a higher uterine artery PI? This is because of ethnicity, because of genes, and higher underlying prevalence of hypertension and metabolic disease in Asian Indian women compared to Caucasians. And that is why we need our own cutoffs, our own reference ranges for Indian population, because so far we are assuming reliability of global reference charts. We really need to check the interpretations in Indian context, for which we need a large database to minimize errors. And to collect data, we all need to contribute. This is IRIA website. Go to the program option, Samrakshan forms, and you have all the forms right there. So either you could fill the trimester specific forms online, or you could download the Yodha Excel sheet from this download forum, and this sheet you could fill offline and submit at Samrakshan once a month. Now, this paper, Effectiveness of the First Trimester Samrakshan Protocol for the Identification of Pregnant Women at High Risk for Preterm Preeclampsia. The First Trimester Samrakshan Protocol, which we know is the triple, we include maternal characteristics, mean arterial pressure, and uterine artery PI to find the risk. This identified women at high risk for preterm preeclampsia with high specificity of almost 90% and negative predictive value of 98%. That means a high specificity indicates that a pregnant woman identified as high risk using the protocol is likely to develop preterm preeclampsia. High negative predictive value indicates that the women who were screened negative were not truly at risk for preterm preeclampsia. And it was seen that just 2% of women who were identified as low risk developed preeclampsia. And out of the high risk group who were put on ecosprin, 80% did not develop preeclampsia. However, 20% of high risk group on ecosprin also did develop preeclampsia, but it was later, if it was destined to happen at 26 weeks, it happened later on, maybe 32 or 35 weeks. So what does that imply on financial aspect? Well, cost of aspirin 150 milligram from 11 to 36 weeks is 175 rupees per high risk woman. So the cost of treatment all through the pregnancy is just 175 rupees per woman. Cost of managing preeclampsia, if the woman is not put on ecosprin and develops preeclampsia, the cost is around 1.5 lakh per case. And extrapolating Samrakshan results for Indian population, we found that preeclampsia was averted by Samrakshan protocol in 15 lakh women out of 24 lakh women who could develop preeclampsia. And this is the cost saving which we could achieve. So let's do some arithmetic. Preterm preeclampsia reduced from 10% to 3%. Cost of ecosprin per pregnancy 175 rupees. Cost of 2 BP apparatus that a physician needs to do mean arterial pressure about 4,000 rupees, and Doppler studies an additional 2 to 5 or maybe 7 minutes per woman. So compare the time and the money that you invested with what we have achieved, saving 80% of high-risk women from developing hypertension and its complications, and saving as many babies as well. Now this paper, a comparison of changes in the mean arterial blood pressure and mean uterine artery PI from 11 weeks to 20 weeks in low risk and high risk Asian Indian pregnant women. And the article reveals that in our population, there was a declining trend of mean uterine artery PI from the first to second trimester. 35% of women with abnormal mean uterine artery PI in the first trimester had an abnormal mean uterine artery PI in second trimester as well. So 35% continued to have a higher mean uterine artery PI in second trimester as well. Now 10% of women with normal mean uterine artery PI in the first trimester had an abnormal PI in the second trimester. And high-risk women taking aspirin showed a greater reduction in mean uterine artery PI compared to high-risk women who did not take aspirin. Another paper, prioritizing fetal structural abnormalities over risk for preeclampsia and fetal growth restriction in the 20 to 24 weeks risk assessment in India. Missing the woods for the trees, and that is my favorite line, because if you look at the incidence of congenital anomalies, it is approximately 2 to 3 percent. Incidence of FGR 25 to 35%. Incidence of preeclampsia is 8 to 10%. So by only doing the anomaly scan at the time of TIFA scan, we are missing the woods for the trees. The study showed a significantly low prevalence of congenital abnormalities compared to women diagnosed with early preeclampsia and FGR. Therefore, second trimester assessment of pregnant women in India must expand its scope from the TIFA scan to also focus on screening to identify women at high risk for preterm preeclampsia and FGR. This paper in IRIA about color Doppler ultrasonography in the third trimester of pregnancy significantly reclassifies fetal growth restriction in the Samrakshan program of IRIA. Now, what does that mean? About 22 lakh FGR babies were reclassified as SGA on integration of color Doppler. Reclassification to SGA is useful as it helps to determine the interval between follow-up assessments and provides an objective pathway to decision on mode and timing of childbirth. So there was a tremendous implication on healthcare system, cesarean sections, preterm delivery, and perinatal mortality rate. Another paper on third trimester screening. This is a preterm birth rate after initiation of third trimester screening protocol of Samrakshan in India. Initial results, and the results showed a reduction of preterm birth from 23% to 10%, that is less than half. And this could be achieved by using Dopplers for stage-based management for FGR. So what is the way forward? How the Indian scenario of perinatal mortality will change if we all radiologists of India start preeclampsia and FGR screening in the first trimester. Total pregnancies in India about 30 million per year. Out of this, approximately 8% are at risk of preeclampsia, that is 24 lakh. And if preeclampsia screening is done in all of these by the triple technique, that is maternal characteristics, mean arterial pressure, uterine artery PI, we will be able to detect 80% of high-risk women. That is, we can detect 20 lakh women. And giving EcoSprint to all of these will benefit 80% of women, that is 16 lakhs. So we are bound to benefit 16 lakh mothers and as many babies if we all embark on this mission of Samrakshan. And what is the vision? Samrakshan 757. That means extending Samrakshan, scaling Samrakshan to 757 districts of India to reduce preeclampsia to less than 3% from current 8 to 10% and growth restriction of babies to less than 10% from existing 25 to 35%. So we aim to have one Samrakshan radiologist in each district. If we can, you can. And each one of you matter in the endeavor towards safe motherhood, which is a right of every single woman. Thank you very much.